again, thank you to the organizers for the kind invitation. My brief is to give a case about refining patient selection for ICD beyond ejection fraction. And I thought I'd share with you a recent clinical case. This is a 26-year-old Saudi project engineer who was referred to the emergency room by his general practitioner on September the 21st this year. And the history he gave was that he was a non-smoker on no medication, no prior medical history, no family history of heart disease. He did complain of chest pain, breathlessness, and palpitation on exertion that sounds cardiac. He denied any syncope or pre-syncope. Physical examination was remarkable for the fact that he had a grade 2/6 ejection systolic murmur. And this was his electrocardiogram that shows perhaps some terminal T inversion in V2. And his cardiac troponin I was borderline elevated. Our cutoff is 0.03. So he had an elevated biomarkers, an abnormal EKG. Chest X-ray was unremarkable. And because of this murmur, cardiology was involved when we performed an echocardiogram, which this is a parasternal long axis view, shows a very hypertrophied left ventricle, particularly with asymmetric septal hypertrophy. Septal thickness is 2.3 centimeters, 23 millimeters. This is a short axis view, again confirming the presence of marked hypertrophy, also involving the right ventricle, very thick septum. Echocardiography shows a very low gradient in the outflow tract. There's no significant SAM motion. So at this stage, I went back to the patient and said, look, it looks like you have very thick heart muscle. You most likely have a condition called hypertrophic cardiomyopathy. And I said, you know, I want to tell you more about this condition. And then he told me, well, actually, I've had serial echoes over the last 9 years, and the last time I was told the heart was 22 millimeters thick. And I said, well, come on, give me more of a history. And he said, well, actually, it does run in the family. He said he had 3 brothers and 3 sisters and a mother, all have something wrong with their heart muscle. His father died at 65 from some sort of heart operation, and an older brother is 46 years of age and has a pacemaker ICD implanted. And digging further, he said a distant cousin died suddenly at 18 years of age. So I said to him, well, yeah, Sheikh, why didn't you tell us this up front? And he said, well, I'm testing you. I want to see how good you are. Because really, your missions, should you seek to accept, is, do I need a pacemaker ICD like my brother? So what can we advise this young man? We know that hypertrophic is the most common genetic cardiomyopathy across multiple ethnicities. The prevalence is approximately 0.2% or 1 in 500 of the population. It usually follows an autosomal dominant inheritance pattern. Most patients have a relatively benign clinical course and natural history, but sudden death can occur in about 1% of hypertrophic patients every year. And ICD implantation can reduce mortality in these patients. The usual cause of death in these patients is ventricular fibrillation triggered by a combination of the substrate, the structural abnormalities, some transient functional abnormalities, perhaps small vessel disease, outflow tract obstruction, autosomal dysfunction, triggered by an electrical impulse like a PVC resulting in VF. And there are guidelines that have been around for a while, the ESC Guidelines in 2003, then the 2011 ACC-AHA guidelines. We'll come on to the 2015 guidelines shortly. But high-risk features would be non-sustained ventricular tachycardia, an abnormal blood pressure response to exercise, unexplained syncope in the patient, not due to vasovagal effects, family history of sudden cardiac death, maximum wall thickness more than 30 millimeters, and other modifiable risk factors. And the recommendation was if you had a single risk factor, you could consider an ICD. Multiple risk factors, definitely an ICD, but no risk factors, an ICD isn't recommended. Why don't we just put an ICD into everyone? And this is from various studies of ICD therapy in hypertrophic patients. And if you look at the blue at on the right-hand side, these are appropriate therapies or appropriate shocks. The purple are inappropriate shocks, and the orange are implant complications. So this particular population, and these are from good centers, these particular population do have a higher incidence of complications, and they do have a lot of inappropriate shocks. And again, we've mentioned the major risk factors: non-sustained VT, family history of sudden death, abnormal blood pressure response to exercise, unexplained syncope, and maximal wall thickness. But there are other features associated with sudden death in hypertrophic cardiomyopathy, including young age, LVOT obstruction, AF, LA dilatation, fractionation of the paced ventricular electrocardiograms, ischemia, certain mutations. There are certain high-risk gene mutations, and left ventricular apical aneurysms. In terms of imaging, we have a consensus, expert consensus position paper from the ESC, which has been endorsed by the Saudi Heart Association. This is in 2015 for imaging patients with hypertrophic cardiomyopathy. And if we're looking for various features of hypertrophic cardiomyopathy, in this case we're looking for sudden death profile. Certainly echo and CMR have a great role, and perhaps cardiovascular CT looking for ischemia of the coronary arteries. But certainly looking for fibrosis is indicated. Fibrosis is very common, occurring in 2/3 of all patients with hypertrophic cardiomyopathy. It does follow two specific patterns, the intramural and RV insertion point. And the load of fibrosis correlates with prognosis and increases the risk of sudden cardiac death. So we look at our patient again. He's got marked septal hypertrophy. He has a relatively low outflow tract gradient, even after a Valsalva maneuver generates a gradient of only 14 or 15. If we look at Speckle track echo, looking at global longitudinal strain, in a sense is a poor man's late gadolinium enhancement. It does correspond to fibrosis within the septum, and our patient had a very abnormal Speckle scan here with late longitudinal strain, and this gives a classic pattern of hypertrophic cardiomyopathy with reduced longitudinal strain in the septum on the bullseye view. And this corresponds to a CMR. And again, the multimodality paper, position paper, recommends CMR on all patients at least once in hypertrophic cardiomyopathy. Again, a very thick septum, and on CMR, actually his septal thickness is approaching 30 millimeters of mercury, 30 millimeters. And he does have late gadolinium enhancement, as you can see on the arrows. So where do we go from here? We know that VF is the most common cause of sudden death in hypertrophic cardiomyopathy. It may be prevented by an implantable defibrillator. Every HOCM patient should undergo a comprehensive assessment of sudden cardiac death risk factors, looking particularly for non-sustained VT, family history of sudden death, unexplained syncope, abnormal blood pressure response to exercise, and maximal wall thickness. ICD therapy should be offered to those with multiple risk factors, and patients with no risk factors should be reassured and regularly assessed. Single risk factor for sudden death carries a good prognosis, but ICD therapy may still be indicated in a minority of these patients. Unfortunately, our current risk stratification is still somewhat limited, and hypertrophic patients who do receive ICDs have a higher incidence of inappropriate shocks and complications from the device. So the question is, would you recommend an ICD in this patient? He's got significant left ventricular hypertrophy. He has a family history. His family history, he doesn't have sudden death in an immediate relative, but his father died at 65, we're not sure. His brother has had an ICD. Was that for he's not sure of the indication. A distant cousin died suddenly at 18. His Holter monitor is normal. Exercise testing, he's a little bit of an unreliable guy. He still hasn't shown up for his exercise test. Are there any guidelines that can help us? The 215 ESC Guidelines for the Management of Patients with Ventricular Arrhythmias and Prevention of Sudden Death, They do recommend as a class 1 indication, the third one there, risk stratification with the HOCM patient using the sudden death calculator for patients who are over the age of 16 without a history of VT or VF or hemodynamic compromise. And in the ESC 2014 HOCM guidelines, there is a risk calculator, and it does recommend checking this. It's actually quite a complicated formula, and you can work out the probability of sudden death at 5 years by multiplying these various equations: prognostic index times maximal wall thickness, left atrial diameter, ICD implantation could be considered as a 2A indication in patients with more than 6% risk at 5 years of sudden death following a detailed examination. It could also be considered as a 2B indication if the risk is between 4 and 6% as well. So I'm going to hand over to the experts now and find out how we should proceed in this patient. Thank you very much.
Many thanks for this very